Hello everyone, welcome to Tutor IMG's short medical series. We're continuing our AVNRT treatment part, and in this, I'm going to be taking a look at exactly how to terminate a supraventricular tachycardia. Now, when we have a patient who is experiencing AVNRT, most of the time they are going to be hemodynamically stable. It's very rare to have a patient in an AVNRT end up with hemodynamic instability, right? Also mentioned before is the fact that most of our AVNRTs are the slow-fast AVNRT pathways. Now, because the AV node is under control of the vagal nerve, one of the main ways in which we can control these AVNRTs is to stimulate the vagal nerve. How do we stimulate the vagal nerve? We perform certain vagal maneuvers. And one of the first ones we do is the Valsalva maneuver. We can also do the carotid massage maneuver. In patients who are experiencing this for the first time, maneuvers like these can, of course, terminate the AVNRT, which is perfect. However, if these maneuvers fail to do their job, then there are certain things that we can progress towards, and that's the pharmacological management. Remember, the pharmacological management kicks in after the vagal maneuvers have failed. What is the pharmacological management? The first thing we do is turn towards IV adenosine. Now, the one thing I want to point out is that at any point in our management, whether it's after vagal maneuvers or after IV adenosine, if we find that the patient's rhythm and heart rate is restored, what do we do with them? We will, of course, not just leave them be, we will want to follow them up. And this is something that you have to watch out for and mention on your short case questions, where a question about AVNRT will expect that you should understand that these rhythms can point to an underlying pathology. So you do need to further follow them up and perhaps treat the patient if the episodes keep recurring. Treatment in such patients will include giving them certain AVNodal blockers. And the AVNodal blockers that we look at are the non-dihydropyridine calcium channel blockers, which include verapamil and diltiazem. We can also give them beta blockers, as long as they don't have any contraindications to those, right? Other things that you can offer them, of course, when you're following them up, is to look for angina and heart failure symptoms. Now, we were looking at IV adenosine. And IV adenosine, as I mentioned before, is something you resort to when vagal maneuvers have failed. IV adenosine usually resolves the problem, and then you follow this limb. If it doesn't resolve, and if the problem persists, you can repeat IV adenosine for the second time. If the problem resolves, you go back to your follow-up. If the problem persists, you repeat IV adenosine, this time slightly higher dose. At this point, after hitting a certain peak dose and repeating things for 3 times, if the patient still persists, you will not use IV adenosine. There's also a scenario where the patient settles partially with IV adenosine and then relapses into the rhythm as you watch. So if that's the case, you can add either a beta blocker or a non-dihydropyridine CCB. Usually adding this will resolve the issue and you can go to this limb again. If it persists beyond this management, you have to label it refractory and unstable AVNRT. It could also be that it's not an AVNRT and it's refractory unstable tachyarrhythmia, which needs further evaluation. So you need to reconsider your diagnosis. You can also offer this patient a cardioversion. A more definitive management of AVNRT is catheter ablation. We go in and we ablate or kill off the one of the pathways. Usually we kill off the slow pathway and allow the usual normal pathway to exist and conduct, as it would normally do. This resolves problems in about 95% of the cases. So I hope you enjoyed this video, and please keep supporting our videos for more such informative sessions. Thank you very much.